Good morning, everyone. I hope people can hear me. Can you just make sure that I'll just wait for 1 minute for you to type in to say that you can hear us clearly. So if you can, on the left side of your screen, you can type your messages in, and if you can signal to us that you can hear us well. Thank you. Great. So I can see that hear us. So if there's anybody that is having any problems, just again have a couple of minutes to make sure that your system is correctly logged on. After this, please make sure that your microphones are on mute. Then before we start, in about 3-4 minutes, I'm going to give the floor to Jessica Rodriguez, who is here with us in New York from the IATT Secretariat, to give us some guiding points on how you can participate in the question and answer part. So over to Jessica.
Thank you, Tintin, and welcome everyone. Thank you for joining us on time. A few tips and pointers for logging into the webinar and hearing clearly. One is to ensure that your application is installed properly. So if you're having some trouble hearing, if your microphone is grayed out, that might mean that your audio isn't working to its full capacity. So I would suggest that you try logging in and out of the call. And alternatively, you can also restart your computer, because that might help your computer application has been installed. In addition, after each presentation, we'll have a Q&A period. So you can either type in your questions and we'll log them and repeat them out loud and direct them to the presenters, or you can also unmute your mic and ask your question to the presenters. So that will be after the presentations, and we'll clearly moderate that and indicate when it's time to ask questions. Also, if a question occurs as the presentation is going, you can feel free to type it in. I think that is all for now. Also, if you would like, we know that the audience is WHO and UNICEF staff working in nutrition, health, and HIV. And if you can kindly let us know which country you're calling in from and which organization you're working for, that would help us a lot to know who has participated and to be able to distribute any follow-up information. Thank you. You can type in that information. So country and which organization you're calling in from. Thank you so much.
Thank you, Jessica. So we will just give 2 more minutes for other participants to join. And we will start at 8:30 a.m. Eastern Standard Time, 14:30 Central European Time on the dot. So 1 or 2 more minutes. Thank you. Good morning, good afternoon, everyone. Thank you for joining the webinar on the upcoming 2015 HIV and infant feeding guidelines. This webinar has been co-hosted by WHO and UNICEF, and we welcome you to this call. We are going to have this webinar for an hour and a half until 10 a.m. in the morning or 4 o'clock in Europe. My name is Tintin Sint. I'm the HIV and nutrition focal person in UNICEF based in New York. And this morning we are going to have 3 presenters in the webinar. We will have Dr. Nigel Rowlands from the Department of Maternal, Newborn, Child and Adolescent Health based in Geneva from WHO. Myself and Chiho Suzuki from Data and Analytics Section in UNICEF based in New York. And we have the honor of having Jessica Rodriguez, Interagency Task Team Secretariat, who is going to moderate the Q&A sessions. The webinar will have 3 main parts. So we will have then the guidelines presentation by Nigel, and then we will have a clarification Q&A session moderated by Jessica, followed by next steps for support and monitoring and reporting issues presented by myself and Chiho, and another question and answer session moderated by Jessica, and a wrap-up by Nigel and myself. So with that, I would first like to hand over the presenter to the first presenter, Nigel. And Nigel, if you could, I will introduce you already, but if you could say a few words about yourself and then take the presenter. Thank you.
Thanks, Tintin, and looking forward to this session. I hear a bit of an echo on my side. Is there an echo with you?
It's fine.
It's fine, good. Then this type of a presentation to you and staff only is a little bit different from some of the webinars that we have done before. It's different in the sense that as much as there is information sharing, we also want to have a discussion between the UN family on how best we can help and work with governments and implementing partners to really use these guidelines and to help adapt policies locally for the future. So I'm just going to take, I think, Jessica, hopefully I should be just taking over the presentation now. So this first slide highlights just over the past 5-6 years there have been a series of guidelines, and in fact there are guidelines on HIV and infant feeding dating back to about 2000 and even before that. But there were some significant changes in 2010, both in terms of the ART guidelines and also the infant feeding guidelines. And then there was also the fact that there was a shift in the way that guidelines were organized to have things consolidated. So the 2010 guidelines for antiretrovirals, for the first time, they included antiretrovirals for the prevention of postnatal transmission of HIV. And it seems a long time since those have come out. In response to that, the infant feeding guidelines were also reviewed, and there were 2, although there were several recommendations and principles within that, I'm really going to focus on two of those, which were in many ways game changers. In comparison to the previous guidelines, where individual health workers were asked to counsel individual women, the guidelines presented a public health approach, whereby the responsibility for making a decision about what health services would offer was to be taken at national level, and that a decision would be taken in principle whether health services would promote both breastfeeding and ARVs for all women living with HIV within that country, or if the health services would principally promote the avoidance of all breastfeeding. And the endpoint that we're all interested in is HIV-free survival. And that decision at national level was to be based on consideration of the socioeconomics and cultural settings where their specific services were offering services. And then secondly, the epidemiology of both HIV and also infant and child nutrition and also maternal health status. The second main recommendation that I just want to focus on for now was that when a country had decided on promoting and supporting breastfeeding with ARVs, and obviously that wouldn't be relevant in all settings globally, but where it was adopted by a country, then it says that mothers known to be HIV infected and whose infants are HIV uninfected should exclusively breastfeed their infants for the first 6 months of life, introduce complementary feeding thereafter, and continue breastfeeding for the first 12 months of life. Now, those recommendations are completely similar or completely the same as for mothers who don't have HIV, apart from that 12 months where the timeline of 12 months is definitely HIV distinct and characteristic. And the basis of that was the evidence at that time that antiretrovirals were very effective, but there wasn't any uncertainty about whether the ARVs would be effective for a long period of time. And it was then saying that breastfeeding should then stop only when a nutritionally adequate and safe diet without breast milk could be provided. Now, since then, the vast majority of countries, in fact, of the 22 UNAIDS priority countries have all adopted breastfeeding. 2 countries also recommend breastfeeding, but they actually suggest an individualized approach to being much more supportive and promoting breastfeeding with ARVs, but without a formal policy across all. And it needs to be highlighted here that there is no obligation by women to breastfeed. Mothers would always still have an option of choosing and continuing replacement feed if that's what they wanted, but that this is a question of what health services would offer. So following those guidelines, there were several questions that arose from countries, namely, can a country recommend exclusive breastfeeding and ARVs even when rates of exclusive breastfeeding are low? And then there was the question, do women really need to stop breastfeeding if they are on lifelong ART? And of course, many things have changed in terms of guidelines towards B+. And then there was the question, if the mother is not exclusively breastfeeding, but for example mixed feeding in the first 6 months, then what should she do? Should she stop breastfeeding altogether? And if she's intending to return back to work, for example, or go back to school, then should she ever start breastfeeding if she knows that she's not going to breastfeed for a full 12 months? And in the first years after the 2010 recommendations, there were a couple of studies that looked at practices in the Southern African region, and this was one statement that said that findings that exclusive breastfeeding in resource-limited settings are not being translated into action by governments and frontline health workers because of a variety of structural and ideological barriers. And to me, that was really talking about confidence amongst health workers to recommend breastfeeding. And so I just want to put this slide in, because it's a slightly unusual one maybe in the sequence, but I'm going to come back to this at a later stage. This was a study that came from Botswana. It was a randomized trial of different drug regimens looking at postnatal transmission. Now, the importance of this slide is not about the transmission rates, which were actually very, very low. And you can see that a little bit on the left-hand side. But it was really coming back to this question of confidence amongst health workers and amongst communities. So for this study, they needed to recruit about 1,000 women, 1,000 women who would breastfeed, not give formula milk. And this was in a country that for 10 or 15 years had been strongly promoting replacement feeds. So in the study, they approached and invited 1,248 pregnant women to join the study. And only 110 of those women chose not to participate in the study because they preferred to give formula feeds. So one of the big points here was that even in a country like Botswana, where there was high acceptability, and in fact it was usual practice for HIV or for mothers living with HIV to actually formula feed, there was a high acceptability of breastfeeding as long as they had been counselled well and that antiretrovirals were consistently available. So if we were to say, and this was actually a slide from 2011, if we were to say what would we ideally want, well, we would love to be in a place where when mothers living with HIV breastfeed, that there is zero risk of HIV transmission. We would like to be in a place where both HIV-infected mothers have confidence in breastfeeding and all the benefits of breastfeeding, and that health workers would equally be confident to promote and support breastfeeding, and where there was no negative connotations, no stigma associated with breastfeeding or with ARVs. So we come now to the guideline process, and in 2014 there was an initial scoping, and that's whenever a group of experts reviewed the guidelines from 2010 and said what were the top priority areas where there was maybe new evidence or still major questions. And these were the 4 areas that were identified for primary review. For how long should a mother living with HIV breastfeed her infant or child if she is being supported with ART? Secondly, and this maybe seems a little bit obvious, but should women living with HIV be supported in facilities, in communities, with respect to their infant feeding practices? And if a mother living with HIV is actually mixed feeding, then are antiretroviral drugs still protective against postnatal transmission? And if a mother with HIV plans to return to work or school, should she breastfeed her infant for shorter than recommended or never breastfeed at all? There were 3 other areas that were discussed, but that really weren't guideline issues. Well, not at least at this time. What to recommend in emergencies and humanitarian disasters. A month after the publication of the 2010 guidelines, there was the earthquake in Haiti, and yet the 2010 guidelines didn't say anything about emergencies. And over the past year or 18 months, we've been receiving questions, especially from the Ukraine, about what should be recommended to women living in Ukraine who are caught in the conflict and who are having difficulty with water, electricity, but are also having difficulty with antiretroviral drug supply. The second question was, what are the implications for routine M&E? And colleagues from UNICEF will speak to this more. And then finally, how should these guidelines be disseminated in the future? So this is just a reminder that the guidelines on HIV are very closely linked to whatever is recommended on antiretroviral treatment, and that between 2010 and 2015, WHO recommendations on treatment have evolved, and at the moment we are recommending lifelong treatment for all from whenever anyone is diagnosed. And so that progression, and that's the context for these recommendations, and that's an important point. So this is the first recommendation, and this is still in truth drafted. It should be approved and finalised by the GRC, the Guideline Review Committee, within the next week or so. The guideline has actually been approved. There are some minor edits, but this is probably what it's going to be. So this is the recommendation. There's two of them, in fact. In settings where health services provide and support lifelong antiretroviral treatment, including adherence counselling, and promote and support breastfeeding among women living with HIV, the duration of breastfeeding should not be restricted. Mothers living with HIV should breastfeed for at least 12 months and can continue breastfeeding for up to 24 months or longer while being fully supported for ART adherence. So the recommendation up until 12 months was supported by low quality of evidence, and the evidence up to 24 months was regarded as very low quality, mainly because of indirectness. But it was recommended by the Guideline Committee as a strong recommendation. The second recommendation is that national and local health authorities should actively coordinate and implement services in health facilities and activities in workplaces, communities and homes to protect, promote and support breastfeeding among women living with HIV. And this is different from the 2010, where it simply made a principled statement that support to women was important. And so this recommendation not only says that there should be active protection, promotion and support to women living with HIV, but it also emphasises that it needs to happen in workplaces, communities and homes, and that the health services have a role within that coordination. Now, this next slide is a little bit, needs a little bit of explanation, because it is not a recommendation. It is referred to as a guiding statement in settings of suboptimal practices. So the reason for this is that WHO did not want to undermine exclusive breastfeeding in any way, and yet it recognises that in many places women do not exclusively breastfeed. And so for that reason, this guiding statement is not a recommendation in case it suggests to women that mixed feeding is okay. And so when interacting with national departments of health or program implementers or any other partners or health workers, that this is clearly an important statement, but it's not a recommendation in the same way that other positive health recommendations are issued. So this says that mothers living with HIV and healthcare workers can be reassured that antiretroviral treatment is effective at reducing the risk of postnatal HIV transmission in the context of mixed feeding, and that mixed feeding in itself is not a reason to stop breastfeeding. And I can understand that there needs to be very careful messaging here, because we do not want to introduce contradiction or confusion in terms of all the efforts to declare mixed feeding. And yet we need to understand that the drugs are probably still working, and that mixed feeding would not be a reason to actually stop breastfeeding. A very similar situation for this next statement, which is also called a guiding statement, and for the exact same reasons. Mothers living with HIV and healthcare workers can be reassured that shorter durations of breastfeeding, less than 12 months, are better than never initiating breastfeeding at all. And so again, this is to give some guidance in this contingency where women are not able to, or where they are choosing to breastfeed for less than 12 months. So we wanted to stop there just for a moment and to take any questions or clarifications on what we have been through so far, and then to think about any questions regarding monitoring and the emergency. We'll come back to those a little bit later. But maybe we could take some questions now.
Thank you, Nigel. So Jessica will now moderate that session, and as mentioned before, you can either type your question in the conversation part on the left of your screen, or you can unmute your microphone and just introduce yourself and ask the question. Before we start that, I just wanted to say thank you everyone for joining. We are very glad that you could join this webinar. Just to also let you know that we have 4 webinars on these guidelines being planned for the next month. One this month, 2 in June, and we had specifically done that to be able to address the different audiences. So today's webinar, we had mainly targeted our UNICEF and WHO country officers and regional officers in HIV, health and nutrition in this part of the world, Europe and Africa. And we have 3 other webinars where we will be targeting the interagency task team members, so other key implementers. We have one specifically for our country offices, again in Asia and Far East and the what is it called, the Western Pacific region, and we also have one mainly for the U.S. agencies. So if for those who we welcome everybody's questions today, but we hope that as Nigel has said in the very beginning of his presentation, we mainly want to also address some our UN capacity to be able to respond to national authorities on these new guidelines. So with that, I hand over to Jessica to moderate the Q&A session.
Thank you, Tintin. And kindly send in any of your questions or clarifications either by typing them in or by unmuting your mic and feeling free to ask them directly. And also, as Tintin mentioned, as you ask these questions, we hope will enrich the subsequent presentations that we will give on the various webinars. So your questions are very helpful and welcome as we continue to develop and refine the webinar. So the first question is from Florence, and she asks, what will be the advice to a mother who is practicing mixed feeding and also has poor ART adherence?
Thanks there, Florence. Can you hear me still okay, yeah?
Yes.
Okay. So, I mean, I think the situation here is that this is a very difficult situation because she is both in a very suboptimal situation for both feeding and also ART. one of the points about any guideline is that the guidelines provide general direction, but they can't get down to the specificities of each of these. What I would say in this situation is that this is clearly the circumstances within which that mother is living is either very challenging. I think that the effort from the response from the health system has got to be to really increase their support to the women, obviously on both of those accounts, on both feeding and the ART. I would prioritize the ART because the ART will protect the child and will also protect the health of the mother. So in that sense, I think the top response from the system would be to try to improve ART adherence. Jessica, maybe I could just go down through the other couple of questions. That work?
Sure.
So the second question from Gabriel is, what is the advice for situations where ART may not be initiated late or early in, where ART may only be initiated late in pregnancy or even during delivery? The guidelines now in terms of ART clarify this in terms of the infant prophylaxis. So the evidence on infant prophylaxis is that it works. The rationale for promoting ART in all individuals is not firstly to protect against breastfeeding transmission, but it's because of the benefits to the mothers and adults and everybody. So the main, as much as that is the case, it's also very true to say, and even there have been studies published within the past 18 months that show that infant prophylaxis is very, very effective, but clearly it does nothing for maternal health. And so for women who are starting late in pregnancy or during delivery, then the importance is to make sure that the infant gets the prophylaxis, that the mother understands how important it is for consistent delivery of the drug to the infant while breastfeeding, and also the importance of getting onto consistent treatment for herself, because the antiretrovirals to the infant will definitely protect the child, but you want to get to a situation where the mother is being protected and the viral load in breast milk is also then being reduced by the maternal ART so that the infant prophylaxis becomes no longer required. Is that clear there, Gabriel, or is there anything else there? And the same to about the earlier question from Florence. Is there anything else there? And then I'll go on to the comment from Ada. And the question there from Ada is, from what you've presented, the recommendation for breastfeeding is the same for HIV negative as for HIV positive. And that's generally the case, that the guideline group said that as long as there is good adherence, then the group did not feel there was a necessity to differentiate between mothers with HIV and those without HIV. I think it's also true, and the language, the full document, does discuss this much more. I'm just going to go back here for a second, Jessica, to one of the slides.
Sure.
Because there's an important point here. So if you look, there are two parts to this, and it says that the duration of breastfeeding should not be restricted. And then the second bullet says that mothers living with HIV, they should breastfeed for at least 12 months. So that's a very definite statement. But the second part is that it goes on to say that women can continue breastfeeding for up to 24 months. It's not saying that they should. The highest benefit is in the first 12 months. that the benefits between 12 and 24 months are very much more individually dependent, but that while she is taking ART, she can do so. So after 12 months, I think that that decision is much more for the woman to make for herself, but that it's not an absolute clear 12-month stop. If she is wanting to breastfeed, if she's taking her treatment really well, then she should be given the support to carry on. Is maybe Ada, is that clear? So I think Ada has lost the connection. I can also drop a note to Ada about that. We're going to come back to the emergency discussion a little bit later, but there's a question from Fatima. Given the normalization of breastfeeding irrespective of HIV status, will there be a revitalization of BFHI to promote breastfeeding and provide more practical support? This initiative was quite successful in some countries but lost traction in the context of HIV. And this was one of the big discussions underlying the recommendation on health services actively coordinating and supporting breastfeeding across the population. And so there will be one of the slides that will come later will say that all the various tools and guidelines need to be adapted to these updated recommendations, and certainly that will be true for BFHI as well. But here in Geneva, we have very limited opportunity to do some of those things, and that's where the hard work actually comes within country. I think what we're wanting to communicate with this webinar is that, for example, on the support for women living with HIV, there's a high quality of evidence. There's high quality of evidence about the effectiveness of interventions for improving breastfeeding practices, both amongst women living with HIV and also women who do not have HIV. So there's a very strong rationale and justification to improve or to invest in that type of support. There's a very strong rationale and justification for that, in that it's going to improve practices, and that will have an impact on both child mortality amongst those who are exposed and also in the general populations. So Fatima, the answer is yes. We would sincerely hope that this will lead to a revitalization and greater, or really some of the removal of the complexity that there has been around promoting and supporting breastfeeding in years gone by. So we're going to, Maria, there's a comment in terms of indicators. We're going to come to a discussion on M&A in a few minutes. From Gabriel, what happens to HIV testing at 1 year previously conducted after cessation of breastfeeding for 6 weeks? Well, the previous recommendation in terms of testing after the conclusion of breastfeeding would still hold. Clearly, it's going to be more difficult to be absolutely specific as to when that would be, because the testing at 1 year, if you look back at the old former recommendation, it wasn't a hard and fast that they should breastfeed for only 12 months, because the second part of that recommendation said that breastfeeding should then only stop once a nutritionally adequate and safe diet without breast milk can be provided. I think the interpretation of that previous recommendation was breastfeed through to 12 months and then do HIV testing. But it's not absolutely explicit. So in the same way that women could have breastfed for longer than 12 months in the past, in the same way we are encouraging women to breastfeed for longer now while taking ARVs. But that does mean that the exact timing of testing is going to be more fluid, is going to be more flexible than simply saying 12 weeks plus 6 weeks, or 12 months plus 6 weeks. So Tintin, my suggestion is that we maybe just move on ahead. One of the points that had been asked to us, does this recommendation change in any way? And my first reaction was, well, I think most of the countries have actually all made a decision. But then Tintin reminded me, and this was actually from some of the experiences I had traveling with Ruslan in Eastern Europe. There are countries that in the past, so there's someone maybe could mute their microphone. They're talking in the background. Could everybody just check their microphone? Medina, I think if you could maybe mute your microphone. Thanks. And I think that there is a very good justification. The strength of evidence today about the effectiveness of drugs to reduce transmission is greater than ever. And in fact, there may be countries, you could think of some of the countries in Eastern Europe, certainly a couple of countries I visited with, Ruslan, Tajikistan, Kyrgyzstan, and I haven't been to Haiti, but that was also a country where some colleagues attended the guideline meeting and said that there may be justification, that there may be a reason for some countries to actually go back to this 2010 principle and to revisit that, because the strength of evidence on the ARVs and the benefits, as I say, is greater than ever. Nelly asks the question, ARV is not available, should you still promote breastfeeding in that context? And this question was actually covered in the 2010 guidelines, because if ARV treatment is not available, then the same question is about the consistency of replacement feeds, that it's much, much more complicated to provide replacement feeds consistently, to have clean water consistently, to have electricity consistently, to have working fridges consistently. All of those things are much more complicated than ARV treatment. And so my comment there, Nelly, is that the 2010 guidelines said in those situations you need to revert and go back to the individual counselling of women to understand her circumstances. It's much more difficult to take a public health approach in those types of situations. So the question was raised about emergencies, and we had a long and really fascinating discussion about this in the guideline meeting, and we realized that there's many different types of situations. There's conflicts, there are disasters, recurrent disasters, and much more chronic fragile states, and it's very difficult to know what to do in these situations. There's virtually no research done from these. There's very little evidence. And that means it's very hard to develop a guideline in the absence of hard evidence. But it means that we need to work harder, actually. And one of the questions is now being asked is, how do we adapt the existing recommendations for these types of settings? And so there is going to be a formal meeting planned in WHO, probably in the last quarter of the year, when the right people who are experienced in humanitarian disasters and emergency settings, are going to be meeting with some of the scientists who know the data on the drugs, and together they're going to work out some guiding principles in terms of how to adapt these recommendations to those situations. So nothing really to say at the moment, but by the last quarter of the year, something will be developed. And then I think this is probably my last slide, is just to say that in terms of dissemination, it's important that we build on the existing programs and links within the system, especially around antiretroviral treatment. We certainly need to communicate strategies to communities and health workers especially engaging professional associations. It's my own strong view that there's still a great lack of confidence amongst health workers and communities about both ARVs and the value of breastfeeding. And one thing that I certainly was absolutely convinced by during the meeting was the importance of working with networks of mothers living with HIV, as really, they could be really important people, not just lip service towards them, but to really engage them and to take their lead on much of this. So I think this is actually it. So we will be updating training materials. The guidelines will be published, I'm expecting, within the next weeks. There will then be regional workshops, more webinars, and guidelines will be translated into relevant languages. I think that's it. So maybe if there's any questions on those last couple of slides, and otherwise I'll pass back to Tintin and Jessica for some other discussion on M&E. But maybe we could take a couple of questions on these last couple of points.
Thank you, Nigel. Any other questions that you may have on the last couple of slides? Welcome to type in or unmute your microphone and ask it yourself. If not, you still have some time during the next half an hour or so. Okay, so Nigel, there's one more question.
Yeah. Hi, Francoise. So the question is, how do we better support adherence for breastfeeding women? My point here, Francoise, would be I don't think women who are breastfeeding need something that's different from everybody because of the change to B+. And that was the point I was raising. The entire health system needs to be gearing up for better adherence support for everybody. For women that are breastfeeding, there is a much stronger and greater rationale again, but it's not different. Everybody deserves that same adherence support. There are, and Francoise, you will know this very well, that there are a number of different research studies that are looking at not just adherence, but also retention and care. And it's my view that this is one of the big areas that we have yet to learn. All of this is very good. In some countries, we think that adherence and retention amongst women may be better than the general population. There are some data sets that suggest it may be worse. But certainly this is the area that we need a lot more implementation research. What we can say about breastfeeding is that there's a very strong evidence base about how we support breastfeeding. And that's maybe a different discussion. Jessica, what I'll maybe do is to share with you some of the work that came out of a recent series looking at breastfeeding in general, and that there are a number of interventions that are very effective at supporting breastfeeding. Two quick questions or two comments, one from Christine. In some countries where infant young child CIYFC is implemented, what will be the advice for counselling of HIV positive mothers in the community through support groups? I think the point there, Christine, is that it's going to be that ARVs work, and because of that, mothers can be confident about the benefits of breastfeeding, and that it's a win-win situation, that as long as women are taking ART, their lives and their health is protected, and it enables them to breastfeed their children. David's comment, better code implementation will help to protect mothers from promotion of BMS. That's absolutely true, and there's a new report that has just been released on netcode, and again, Jessica, I'll send you some information that you'll be able to share. And then David just adds on to that, or maybe that's the same comment. So we will share both the data on the netcode and some of the other things. For everybody, I suppose, Hi Daisy. We can try to get the Portuguese as well. We hadn't got that planned. It's all a matter of money, if truth be told, whether we can raise the funds to get more translations done. If anybody has specific questions, please feel free to email me or email Jessica, and we'll try and respond to this across the entire group. Question from Florence: there is still need for further research around mixed feeding in relation to subclinical mastitis. I think, in truth, Florence, that there was a large volume of research done in 2002, 2003, 2004, and yes, it's true that subclinical mastitis is a risk factor for transmission, but the effect of antiretrovirals is, it really just dominates, and it is very, very effective at reducing transmission. And I think as long as women are taking the ART consistently and the viral load is down, the worries about subclinical mastitis, mixed feeding, it almost disappears. Mixed feeding is important because it undermines all the other health benefits of breastfeeding. And so it's still important to promote exclusive breastfeeding because it's important for child health and protecting against diarrhea, pneumonia, malnutrition, all the other things. But the major worry about mixed feeding and HIV transmission is largely resolved by ART. And that's a great way to be able to go forward. And Abigail, your question, we mentioned that earlier. Again, I think the answer to that is in the previous 2010 guidelines, actually. There's a whole section where the title is when ARVs are not available. So maybe I can suggest that you have a look at the 2010 guidelines where there's a dedicated section to that specific question.
And Nigel, thank you for those answers. And maybe that is something that we will need to clarify in the Q&A companion documents, which recommendations or which parts have been updated, revised, and which parts or guiding principles or guiding statements remain the same or have not changed from the previous 2010 guidelines. I think that would be important, that it be laid out very simply so that people can quickly see, and understand the sequence.
So Tintin, thanks for that, and it's an important point in terms of, within UNICEF and WHO, how to communicate. The truth is that the only recommendation that changes is the statement about 12 months, because the recommendation on health services coordinating and leading support, that is a further elaboration. It develops what was already there. It only adds to it. And the two other statements about mixed feeding and the duration, the shorter durations of breastfeeding, there was nothing in those. And again, they really clarify and provide guidance about a contingency. Yep.
Nigel, one last comment from Christine.
So the problem is the community IYCF is conducted by community volunteers and they're not aware of HIV status. What about the stigma? Well, I mean, there are some things that simply cannot be addressed unless you have some knowledge of these things. What can be said, and we have done this in some programs that we've been supporting at district level, is that if you are working in an area where HIV is relatively common, then the community volunteers can say two messages. It doesn't need to be targeted at an individual woman. They can say, breastfeeding for all mothers protects their children, etc., etc., etc. And then they can say, in our community where HIV is a problem for some women, then antiretroviral drugs are very, very effective, and they allow women to breastfeed in exactly the same way as women who do not have HIV. So even if the community volunteers are not aware of the status, they can make overarching umbrella statements to say that breastfeeding is good for all, including HIV-exposed children, and then they can make a general umbrella statement that ART enables women with HIV to breastfeed in the same way because the drugs are so effective.
Thank you, Nigel. In addition to that, as Nigel has mentioned before, from UNICEF and WHO, we are going to be revising, and we've started revising all training materials, including the community IYCF training materials, with to be in line with the new guidelines. So from the global level, we will be revising all the HIV, but also the IYCF materials, so that some of these information are part of the revised training materials. So hopefully that can be taken up by the countries and the national trainings quickly. So I think we have responded to most of the questions as they have come along. Please also be aware that this webinar is being recorded, and we will send you a link where you can go back and listen if somehow you got disconnected or you could not hear in the middle. And then we are also planning to distill some of these questions that would be posed during these series. I mean, we have 4 webinars planned, and bring them into a kind of a compiled Q&A where we will be addressing these back in a written document. So with that, we'll just go on to the next part of the webinar, and we have another Q&A at the end, so you still have a chance to ask your questions. So based on Nigel's presentations and the revised guidelines, we just wanted to highlight a couple of things that would like you to take into consideration. The first thing is, of course, the adaptation of these new guidelines in the countries. So in the past experience, before, or actually after WHO guidelines are issued, UNICEF and WHO has done some questionnaires, send out some questionnaire to countries to see how long it actually takes for guidelines, HIV guidelines, to be adapted at country level. And the past experience has shown that it can take anything between 6 to 18 months for HIV guidelines to be adapted adapted and taken up as national policies in countries. With recent guidelines, 2010 and 2013 and 15, this time has become shorter and shorter. So countries have found a way to basically catch up with the ever-evolving science and guidelines from WHO. So we just want to make sure that the UNICEF and WHO country offices are equipped for this quick adaptation of the HIV and infant feeding guidelines. We are aware that the other treatment guidelines, adult, pediatric, and PrEP and testing guidelines were announced in late last year, but the actual the full guidelines are currently being announced by WHO, and that this HIV and infant feeding guidelines is lagging a little bit behind. We are also aware that in countries, technical working groups and national authorities have started discussions to revise the HIV treatment guidelines as per the new WHO guidelines. So we do not want, or rather, we would like to see that the HIV and infant feeding recommendations that Nigel has just presented are taken into consideration in these current or planned revision of the guidelines. So that is why we are having these webinars even before the guidelines are being announced. And as Nigel said, we hope that the guidelines will be announced published within the next weeks or so. But before that, we are giving you the information so that you can bring this to the table, to the technical working groups, to the national authorities, and make sure that we do not miss the boat where the national guidelines are being revised right now. The other thing is that if in some countries that are really quick and already have decided, or the technical working group has already reviewed some of the treatment guideline recommendations and have, in the final stages of revising the guidelines, if that's the status, then is there any way to include the recommendation on infant feeding as a policy brief or addendum to this? So just to ensure that UNICEF and WHO offices in the countries are bringing this to the attention of the technical working group and authorities, and that the infant feeding recommendations are part of the revision. It is very important that the treatment, pediatric treatment or PMTC guidelines and the breastfeeding guidelines go hand in hand, because as Nigel has mentioned several times, the ART is what is the most important thing, and we need to have women tested, put on ART, followed up throughout their breastfeeding period, but also in some circumstances when that is being done late, we need the exposed infant to be put on prophylaxis so that the infant has some ART protection. So with that, what we would like to know from you is, what do you feel that is missing, or what additional support do you need from UNICEF and WHO headquarters for this quick adaptation at national level? So we will welcome any suggestions or questions in terms of the support that you need to make this happen. The next point is then, of course, after you adapt the guidelines, there's the whole part about implementing these. And we already had a number of questions about specific issues, about where ARVs are not available, where the community workers are the ones doing the counseling, etc., which are all programmatic issues that need to be dealt with when you are implementing a program. In terms of that, as Nigel has mentioned, there is also the whole part about the challenge that of having the infant feeding guidelines taken up by frontline workers or community healthcare workers. We have seen by experience, and there are, a lot of reports and documents that says that frontline healthcare workers actually are not confident in saying or promoting breastfeeding with ARV to HIV positive women, and this is the whole issue about the confidence and also their own maybe their own belief that a positive woman should not be breastfeeding. So what can we do to change that confidence in the frontline healthcare workers? What can we also do in terms of supporting the government to plan programs that are holistic, that is not just about the facilities, counseling at the facilities, but also supporting the mother throughout her breastfeeding period. And one of the guiding statements that Niger has put up, or I think, Niger, it is a recommendation that the support, counseling and support for breastfeeding has to be now taken as part of the program. So how can we do that? And that's something that we have to learn by doing, because I think we still have a long way to go. And the second part of the implementation are, of course, the data considerations to be able to report on the HIV-free survival. As Niger has reminded us, all these recommendations and guidelines, the purpose of this is for, in the end, to have a child that is HIV-free and that is alive at the end of the exposure period. So what are some of the data considerations that we need to be looking for? And my colleague will be presenting that after this, after me. The last point that I wanted to make is to let you know that as the guidelines are being published by WHO, we are also planning to have a number of supporting materials and activities. So one of the things is that, as I mentioned, the questions that you have been posing to us today and the questions that will be coming to us in the next 3 webinars, we are going to be compiling them, but we are also reaching out to you to send us more questions around adaptation, implementation, programming, or monitoring and evaluation, so that we can compile all those questions, provide you with some answers, and bring this together as a companion document to the actual guidelines. So we hope to do that quickly. It will depend on your input. If you can send us those Q&As quickly, then we will be able to compile those quickly and come up with a companion document. So one of the proposals that I would like to put on the table is, once you present these new recommendations to the appropriate technical working groups in your countries, as one activity, can you request the technical working group to, compile the Q&As that they may have on these recommendations and send it to us so that we can include it in the companion document. The second point, that materials that we are planning to develop, which is something that WHO does in after their recommendations, is to provide you with a set of slides along with a soft copy of the guidelines that you can use in countries to make your presentation or to make your cases to the ministry and to the technical working groups. So that would be something that WHO would put together. And hopefully, again, as Niger has mentioned, we hope to have that set of slides translated into different languages. But again, it depends on the funding and how much budget we have. So hopefully we can include Portuguese, but that's something that we still have to look into. Then the other 2 things that we would like to, and we are proposing to do, we had a dissemination meeting on these guidelines in late last year here in New York, where some key UN people and other PEPFAR colleagues were invited to, we had agreed to do two things within that meeting, is to have a systematic collection of data points in a few countries. And we haven't identified those few countries, but it could be 2 or 3 countries where we would be supporting these countries and collect data points. And what we mean by systematic collection of data, will come up with that in the next couple of slides that will be presented. And then we also planning to provide intensive technical support to 3 countries to actually monitor the progress on the HIV and nutrition indicators at baseline, midterm, and after 1 to 2 years following the implementation of the guidelines. When we mean monitor the progress, it is not just the programmatic, but also whether the when or whether the guidelines have been brought to the technical working group, presented, adapted, training materials have been revised. So those key things, including the actual program elements. So those are the proposed activities that we have discussed at global level. We will welcome your comments and input into these to say if you think that we have missed any major activities, and then we welcome your feedback on that. With that, I will then give over to my colleague who is going to give you an overview of what we feel are the implications for the monitoring systems in terms in light of the new recommendations. Over to you, Tiho.
Okay, thank you so much, Tintin. Okay, to take over as presenter, right? Okay. Thank you so much, Tintin, and good morning, good afternoon, colleagues. I'm very delighted to present a few slides here for us to trigger some thinking and discussions around what this new guideline means for the routine monitoring system. So, sorry. I did. I am the presenter. Oh, it takes some time? Okay. Here we go. Okay, so the purpose of this presentation is that we're going to review some data on what we consider the postpartum risk of mother-to-child infection, which is the focus of this guideline, some data on infant feeding practices among general population, and drawing from that, consider some implications for what this new guidelines means with respect to monitoring infant feeding period among HIV-positive women. And we're going to end our slideshow with some key considerations to put on the table for discussion for aligning the existing monitoring systems on HIV and infant feeding to the new guidelines. This first diagram should be familiar to those of you in the HIV sector, but I am mindful of the fact that we have a very wide participation this morning. This is just a recap that there are 3 periods in which transmission of HIV can occur from mother to her child: during pregnancy, labor and delivery, and during breastfeeding. Please note that these percentages that you're looking on this chart are without any intervention. So we're not referring to the effect of the intervention on any of these risks. And yes, that was the point I wanted to make. The focus of this discussion, of course, is on the breastfeeding period. This next slide depicts or illustrates the effect of the program efforts that have been taking place over the last 15, 20 years or so to bring down the overall mother-to-child transmission of HIV from more than half in sub-Saharan Africa, from 38% in 2000. So the 38% is the green bar. That is I don't know if it's too small to see on your screens here, but that is the final transmission rate, which is now by 2014 data indicates it has fallen to 15%. So that's a half decline. The blue bar there is the perinatal transmission rate. So the next slide will also, now we're going to focus on those new infections among children. And when you look at the two pie charts here, we will recognize that over the same period of time, the new infections have been reduced. But what you would also note is the proportion of the area covered by these two colors are different in these two pie charts. The focus here for the 2014 is that new infections among children seems to be increasingly concentrated in the postnatal period, which is the period of our concern. So what does that all boil down to? So there's been a lot of efforts on PMTCT with a lot of promising results that you have just witnessed on these two slides. However, that said, monitoring of ARV coverage during breastfeeding and the final assessment of the exposed infant status have been rather weak areas of monitoring the PMTCT cascade. And there's a wide recognition that we need to further intensify efforts to improve postnatal retention of mothers and babies to achieve HIV-free survival. So in the context of this new guideline, which basically allows women to breastfeed for a period up to 24 months and beyond, it's implied that then the HIV-exposed infants will need to be monitored for a longer period. So we looked at some household survey data. We're drawing on DHS and mixed data here to get a sense from the general population, what's the period of breastfeeding in selected countries. And it is mentioned here, we've looked at the sub-Saharan African countries and the 21 priority countries of the global plan. We looked at the household data to look at what is the, how long are the children breastfed for. And this, again, just a reminder, is a general population, not specific to HIV-positive women. What we found among the patterns here is that the majority of children aged 20 to 23 months in sub-Saharan Africa and in the priority countries of the global plan are being breastfed at age 2. The median duration of any breastfeeding for these countries was about 21 months. So some are breastfeeding for much longer than 21, such much shorter than 21. The median is the 21 months. So if we assume that the breastfeeding practice and duration are not very different among HIV negative and HIV positive mothers, then the risk of HIV infection during the postpartum period may go beyond 24 months. But we do have opportunities to, So now on to the children's side. So now we know that the exposure period of the risk, and we know that we need to continue to test children and monitor these infants and children during that risk period. And we are also mindful of the fact that these exposed infants need to be tested at certain periods postpartum and throughout until 6 weeks after cessation of breastfeeding, when the final outcome can be ascertained. And there are opportunities for this through routine immunization, which has been an area of work that has been very much energetic and active with respect to HIV and immunization. So we looked at the data again. This again, we are drawing on the household survey data from DHS and MIX. And what we confirmed was that for the child's first year, DPT3 coverage was nearly 80% in sub-Saharan Africa. But by the child's second year, which I understand is this is the measles-contained virus 2, the coverage drops to about 10%. So to us, this is indicative of possibly reduced engagement of these children with the health systems in a second year through routine immunization. We're also mindful of the fact that the children are immunized in the communities. So beyond the 24 months, we feel that the data is indicating there are fewer routine opportunities, i.e. schedule appointments for the to expect mothers to come in and seek health service for her infant, to allow the health system to continue to monitor the infected child and to continue to test them. There are other opportunities for the children to come into contact with the health systems, and these include when a child is ill with other infections and conditions, such as pneumonia, malnutrition, malaria, tuberculosis, among others. And again, I think this highlights the point that this is an opportunity for the health systems as a whole to work together towards this, the well-being of the children. So now we want to sort of explore here. So with this in mind, with knowing on average, the median period of breastfeeding, the contact that the child might make with the health system through the risk period, now we're shifting gears to, given the change in this guideline, what do we need to know from the routine M&E systems? So this table in front of you is a table of indicators selected from the 2015 WHO Consolidated SI Guide that pertain to retaining women and monitoring HIV-exposed infants till the final status is ascertained. We looked at this, and here is the list in front of you, with respect to what is the reporting status currently. So what are the indicators that are currently in the system that are being reported? What are the indicators that need further disaggregation to look at the breastfeeding aspect of this? And then where we might want to see the countries go long term with respect to the national system's ability to generate this data. The first three indicators are already in the current systems for most of the countries. That is, number of HIV-exposed infants who initiated ARV prophylaxis at birth, number of HIV-exposed infants started on clotrimazole within 2 months of birth, and then the percent of HIV-exposed infants receiving a virological test for HIV within 2 months of birth. You will see that in the next two indicators, we have highlighted breastfeeding. This is because we are mindful of the fact that for the first one, which is number and percentage of HIV-positive breastfeeding women retained on treatment at 6-12 months after initiating ART, countries are currently reporting this, but are not disaggregated by breastfeeding status. So this is something, particularly in light of the new guidelines, is something we want to move towards. The next one, also highlighting the word breastfeeding in red, is a new indicator in the SI guide presented there. My understanding is this is not currently being reported. That is, number and percentage of HIV-exposed breastfeeding infants whose mothers are receiving ART at 3 months and 12 months postpartum. The last two indicators listed here pertain to the final MTCT transmission rate and the exposed infant final outcome status. These two indicators, for now, we are relying on modeled estimates. And with respect to where we would like to see the national M&E systems go beyond this point, is we would prefer this to be two data points for which the program records are able to capture and able to generate this in country. I would like to pause here on this slide. I just have one more slide to go, and would like to go back to one of the indicator questions posed by one of the participants earlier. And I'm now looking across the table to our senior advisor, Priscilla, to see if she's heavily engaged in the global indicator discussions to perhaps give us some guidance on the response to the question, what would be the recommendation for the indicator at the end of breastfeeding period? 12 months, 18 months. Will global guidance indicators change?
Okay. Thank you, Chiho, and good morning, good afternoon, good evening, everyone, wherever you are. I'm Priscilla again, as Chiho has mentioned. I'm the Senior Advisor for our Data and Analytics and also the Chief of Data Analysis Unit at UNICEF New York. So there were questions posed by Maria and Gabriel in relation to monitoring. The first one was in terms of indicators. What would you be recommending for indicator at the end of breastfeeding period? Is it 12 months, 18 months, and will the global guidance on indicators change? Maybe starting with the last question, with the guidance change? No, we just released guidance that actually captures much of what we'll be recommending for monitoring of monitoring of HIV and breastfeeding during the postpartum period. And the guidance is quite new, less than a year or almost a year now. And we are hoping that countries are looking at it and trying to roll it out because there are different indicators recommended. But we note, based on the guidelines that have just been outlined by Nigel, the end of the breastfeeding period will depend on the length to which the mother will breastfeed the child. So we cannot say it has to be measured at 18 months because some mothers might continue to breastfeed beyond that. We cannot say at 24 months because some mothers will continue to breastfeed beyond that. But it could be at the end of breastfeeding period and confirmed 6 weeks after the cessation of breastfeeding, when we know that the injuries related to breastfeeding have been eliminated, is when we can identify when a child would be tested in order to determine their HIV status. So there are several indicators that are recommended in the guidelines at the moment. We have the EAD, the early infant diagnosis indicator, which just during pregnancy. That indicator is very helpful for determining children that need to be initiated on treatment immediately. But we have been talking about at 18 months before because we hadn't considered the length or the duration of breastfeeding across different population groups. Depending on the guidelines that the country adopts and depending on the duration in the country will have to determine at what point will be very optimal to assess the HIV status of the baby or the child. So it's at the end of breastfeeding and 6 weeks after cessation of breastfeeding to determine complete elimination of risk. And what happens to the HIV testing indicator? We shall still continue to have that indicator because we still need to determine children who need to be put on treatment immediately, but we also want to determine the transmission rate during pregnancy and at birth. So that indicator will continue to be collected, and it's also included in the WHO strategic information guidance that was released in May last year.
Okay, thank you so very much for this, Priscilla. I just have one last slide to share with you, and we will now start the discussion. So, in conclusion, we encourage you to take these discussions to countries. We are aware that there are mechanisms in place in countries through technical working groups across the departments within the HIV program, as well as across other health programs where this discussion can take place. And we look forward to hearing the feedback from your in-country dialogue. We see this as an opportunity to further enhance HIV health and nutrition sectors' collaborative effort, coming together and collectively contributing to the health system strengthening and, most importantly, achieving HIV-free survival and better outcome for children. Just to follow up on one of the points in Tintin's slide 2, we are also interested to hear from your perspective of the need for technical support and assistance as you engage in this dialogue. Thank you.
Thank you, Chiho. So we have about 5 more minutes before the actual end of the planned webinar for some questions on the M&E issues that Chiho just presented. So please welcome
for typing those in. But I just wanted to address a couple of points that have come in while there were presentations. It is true that infant feeding is not always attracted the most area of funding, and it may be less of an issue for national authorities. But the point now that is that we need to present this issue about tracking and knowing the breastfeeding practices in light of the mother-to-child transmission, or the EMTCT program. EMTCT is basically, the aim of doing EMTCT is not just to identify positive children and put them on ART, but to also know how many children are, what's the status at the end of breastfeeding. That's the final. That should be the final outcome of your EMTCT program. So to Florence, who is asking what is the incentive it's not to give more money to extend your MTCT follow-up period from 18 months to 24 or 28. The incentive should be something normal. If the new guidelines say you can breastfeed or up to 24 months or beyond, the program should adapt to that, because women may decide to breastfeed longer, and therefore you will not know the end of the HIV zero status at end of breastfeeding for the child unless and until the program adapts to the longer period of breastfeeding, and therefore the program has to follow up these kids longer than 18 months. So I think that's the point that we are asking our colleagues in countries to present to the ministries and to the technical working group, that it is now critical that the PMTCT program and the PMTCT cascade and the data information collection points take into consideration breastfeeding practices, because without those, you are actually not knowing what the outcome of your PMTCT program is. And one of the slides that Hiho showed, which is the 60% or so transmission happening in the breastfeeding period, are estimates. These are models, and we actually don't know whether that 60% is actual real data, the real program, because we do not have this disaggregation of data from the countries. So until and unless that the national programs start collecting breastfeeding practices throughout the whole period, we will keep on using models and estimates, which is not what we want to do. So if countries will take into account in the PMTCT cascade to disaggregate information by breastfeeding or non-breastfeeding women, but also follow up, make changes, necessary changes to the program to follow up HIV-exposed infants until the end of breastfeeding, then all these data will no longer be models, and we will be able to actually report the actual PMTCT or EMTCT program in real. So I just wanted to pitch it in that way. And I think Niger is reinforcing that point, that there's very little actual data from countries regarding the duration of breastfeeding among women living with HIV, because all the data that UNICEF collects are from DHS, are from general population. And so, Nigel, did you want to say something about the point that you just typed?
No, I think it's going to be a question, I think, about these indicators that people will need to engage with over this next 6, 9, 12 months. And clearly there's something of a political angle to it as well. Just how interested are people to know transmission rates? But it's more than transmission. We should really be trying to understand what the survival rate is of these children. But I think that's going to be a longer process within the M&E world to come to agreement on indicators further out. that include both ART coverage and breastfeeding practices amongst these populations.
And maybe just to add on that, with now long-term treatment and ART for all breastfeeding and pregnant women that most countries have adopted, we have to realize that the discussions will have to extend beyond, the maternal and child health clinics. It will have to extend to the ART clinics, and it will have to extend to the nutrition clinics and so on. So there will be a need for political negotiations, even changes to registers and reporting tools, and how the data are disaggregated, because it touches on the well-being of both mother and the child across the health spectrum. It's no longer going to be an isolated discussion, and that is one thing that has to be negotiated in advance, even when we talk about what needs to be collected and from where.
Okay, thank you so much, Nigel and Priscilla. I think I'm just reading Joan's last point, and I think I agree with your point. What we have done, we've come to the end of the allotted time, and we realize that. So what we've done is we have taken note of all your comments and questions regarding also the M&E thing. So please feel free to still type in, because again, as we mentioned, we will take these into consideration when we are compiling our Q&A document. If you have any questions that you were not able to type in while during the webinar, please feel free to send them to Jessica Rodriguez at unicef.org, and she will make sure that those are being addressed in the webinar. So, Nigel, any last words before we close the webinar? Nigel, we cannot hear you. Are you on mute? Are you still there?
Sorry about that. Can you hear me now?
Yes, we can.
Can you hear me? Yeah, just to thank everyone and to say that I was just replying to Joan's point that it's unlikely that we're going to get central funding, but everybody just needs to be opportunistic, and where we can help at HQ level, we would be very happy to. But send us questions for clarification, write to us, and we will do whatever we can.
And with that, thank you everyone for joining, and we're very happy that you made it today, and we hope to continue this collaboration for the next coming months. So thank you, have a nice day, evening, and or night. Bye-bye.
Bye-bye.